All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. These exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
there.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So
Indeed.
Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello, everyone, and welcome back to the GynoCast. My name is Dr. Eric Heegaard,
I'm Twila Dang.
and you are listening to the GynoCast, which I just welcomed you back to.
All right.
So if you're new to listening to the GynoCast, welcome aboard. It's so nice to have you spend your time with us. And if you are a compulsive recurrent listener,
Don't call them compulsive.
all the
We
better.
love them.
We love compulsive recurrent listeners. That's what we
Why
live
can't you
for.
just say,
I guess I shouldn't make it pathologic.
Yeah.
It makes it sort of pathologic.
It makes it seem they're crazy for wanting to listen to us all the time.
Okay, let me just retract that. So welcome. We love people who are supporters of this show.
Amen.
And so what do we do on the show? For people who are new, what is this about? The
Oh,
GynoCast.
we talk about...
What do we do at Twila?
There you go again.
Spit it out.
We talk about anything and everything, women's emotional and physical health and well-being.
That's right.
Yeah.
We talk about the things that people need to talk about. It is important to talk about.
Yes.
But sometimes people don't know where to go. And some of these topics, many of them are things that you may not want to talk about with your grandmother over
Yeah.
tea
Yeah.
and crumpets and cucumber sandwiches,
That's...
for example.
I don't know what you eat with your grandma, but that's what I eat.
Cucumber
And
sandwiches.
crumpets. Okay.
So we are going to continue with our topics that fall into that category of things you may not want to discuss over cucumber sandwiches
Yes.
with your grandmother. But she may want to talk about it because she may be experiencing it, and that is a condition called pelvic organ prolapse. And this is a condition that's not rare, and especially as our population is getting older, as those of us who are aging, we who are fortunate to still be vertical with a pulse, right, Twila? One of the things that can happen is that our pelvic organs sometimes can start to fall under the influence of gravity and start to come out of our vaginas, those of us who have vaginas.
That's okay.
But I'm going to include myself in that because I
Hey,
feel like
listen, solidarity, sister soldier. You've always been the fold.
that's thank you.
It's okay.
And so, but this is something that can affect 15 to 20% of the population. And, you know, we live in a population, I think we figured, that was 350, 370 million people in the United States. Half of those are women.
Yep.
51%. Okay, so let's just agree on 170 million women. Of those, let's just say 100 million of those are over the age of 25. I'm just winging that.
Okay, go for it.
But we're talking tens of millions of women who have the potential for having this happen, and it can be very impactful on a woman's quality of life, her ability to socialize, to be comfortable. And so we are going to be talking about this today. Our guest is Dr. Eric English, who is a board-certified urogynecologist. Dr. English, what is a urogynecologist?
First off, thank you. Yeah, thank you for having me on the show. Good question. Urogynecology started out as it's a slang term, honestly, from an older time. It's people that said, well, I'm going to do some bladder work too, and I'm also a gynecologist. And only recently, it's slang.
It sounds almost disparaging.
At least that's what they said on my
It's like
board
being an
test. That was the
actor
correct
model.
answer on the board test. Yeah, basically it is. It's disparaging. It's a spokesmodel. They're spokesmodels. Now, there's board-certified people, of which I represent. And when we eat our cucumber cakes and et cetera, they became board-certified, and basically female pelvic medicine and reconstructive surgeons, it's a mouthful, FPMRS. These folks, we take special training and have passed a special examination that involves colorectal issues, urologic issues, and gynecologic issues, and you have to know all of them to join the fold.
And this is not like one of those certificates you can get like becoming an online reverend. You know,
Yeah.
I know somebody who became a pastor. You can
I almost
basically
did.
Yeah,
I didn't do it.
you can do that, but you can't just like pay $50 and become a board certified pelvic floor
No,
specialist.
even those of us that grandfathered in, we had to have a tremendous amount of experience. We had to prove it, and we had to do a certain number of cases in a 2-year period across a number of specialties, and it was very challenging. And a lot of people that envision themselves or have talked about it themselves as urogynecologists fell out. They
Couldn't
did not meet the
mustard.
spokesmodels.
Spokesmodel.
Sorry,
So what? So what is?
don't hate.
Stop hating on them.
I know.
So, what is pelvic? What are we talking about? What is pelvic organ prolapse, and why do we care?
It's a dysfunction of normal support of any of the pelvic organs, and
Which include the bladder, the vagina,
and the rectum.
and the rectum.
Yep. And why do we care? It is tremendously destabilizing for people when they can't control defecation, holding urine, or even a patient we saw recently was sitting on her vagina. It was incredibly uncomfortable. She was a healthy lady.
Yep.
Well, she's 75.
70s. Yep.
Yeah. Working out. Looked
Like that.
great. And she stopped working out. It's
Right.
debilitating to
That's
people.
right. She stopped having sex.
Stopped having sex, too.
See, now you know that's my I'll stop right there. Any
know.
any
Yeah.
problems with that? Well, let's go see a doctor and get
Yeah,
some
seriously,
information.
this is. I'm just going to say this woman she looked great. She was vibrant. She liked to hike. She came in and her cervix was out of her vagina.
Yeah.
Whoa.
And she did not like it.
Well,
I will
yeah, I
tell you
would
that.
guess not.
Yeah.
And she's not alone.
Yeah.
So,
And so basically, we like, I'm just going to jump in here and make a universal statement, Twila, which is we like to have our pelvic organs where they're supposed to be, which
Yeah.
is inside our pelvis, right?
right.
Gonna say nobody's gonna disagree on that one.
Yeah.
Yeah.
And, and so the goal, and it's not just, and you mentioned, Dr. English, you mentioned incontinence, urinary incontinence,
Right.
stool incontinence of gas and stool, and that's all part of it. But
Right.
also there's pain related to just the having the uterus, or for example the bladder and the coming out. It's painful.
Correct. It's the normal support structures. They're actually being pulled on. They attach to the inside of the pelvis. They'll feel like a dull pelvic cramping or aching, depending on how vigorous their activity is. It's uncomfortable. At least it can be.
Well, and so tell us. I'd like to go back again. I think for many people, at least in my experience, is that it's kind of intimidating to come in and discuss these topics, and nobody wants to talk about incontinence of urine or stool incontinence, especially,
Correct.
or incontinence of gas and that sort of thing. And it's embarrassing.
Yeah.
It's socially kind of unacceptable to discuss these things.
Yeah. Sometimes, I see people for normal, regular annual exams. They don't come in complaining of this. And I can tell skin changes suggestive of chronic urine contact, stool soiling around the anus, and you can see certain prolapses. And you ask them about it, and some of the symptoms they probably have, they'll deny it for a while. You have to drag it out of them because they usually are either embarrassed, or this problem has been so slow moving, so insidious, like a glacier, they've just kind of accepted it. So they don't see it as abnormal per se. It's just like, well,
It just
doesn't work
happens.
as well as it used to, but yeah.
Mm-hmm.
And what we're going to talk about on the show again is, evaluation and treatment. And I think that I'd like to just put this forth, and just to make sure that people understand that this is not something that is very treatable, successfully treatable.
Yes.
And you do not have to live with this. It's not an inevitable process of aging that you have to sort of just live with.
Correct.
So tell me, a woman comes into your office and with symptoms, or maybe she knows she's got some sort of prolapse, or she just is not feeling good, and you suspect it. What is the evaluation? How do you go about this?
We'll ask a series of questions about the function of the bladder, the rectum, ask about sex performance, pain, some of the things we've already mentioned. And then I'll do what's called a POP-Q exam, where I have them bear down. You hold your breath and push down, and I'll evaluate certain landmark points of the vaginal walls to see how far they've come down, where they're at now, and then we build a stage. We'll stage you then.
And what are the different stages? What are they?
Stage 1 is when things are higher than within 1 centimeter of the opening, essentially the hymenal ring. And some people don't have a sense of that. They don't know the vagina doesn't have a number of nerve endings. So let's say the cervix could be halfway down the tube of the vagina, and the person's only complaint will be that their partner feels like they're bumping into something when they have intercourse. So otherwise they won't have certain other problems. Stage 2 is within 1 centimeter, give or take, the hymen. So it just starts to come to the opening. And at that,
you're talking about either the bladder or the rectum or the cervix.
Yes,
coming down.
Any of those 3 compartments, when that tissue starts to protrude at that point, people notice it. It feels like a stuck tampon. They have somatic sensory, your basic, skin nerve sensation. They'll tell that there's a bulge there. I feel a golf ball, and they'll reach down, usually check it out themselves, and say they get scared, thinking that there's cancer growing out.
And then there's
stage 3 is past 1 centimeter, past the hymenal ring, almost including a total inversion of the vagina. Stage 4 being the rarest, and that is complete eversion of all vaginal tissues.
And so you can another way, and this is another way of saying like mild, moderate, severe, and
basically,
very severe.
Right.
And I know in different conversations I've had with you, you've described this as almost like a sock that's getting inverted.
Correct. It is, and people tend to understand it, and they understand the correction a little bit better when you refer to it as a sock turning inside out.
Help me with that visualization when you're talking to a patient about this. What does that mean?
The vagina is a tube, and it has several different supports along the way, not just 1 or 2, but several. The cervix I would suppose, be the toe of the sock, but a lot of times the toe and the top wall involving the bladder, that's where gravitational, childbirth forces, weight forces tend to apply a great deal of pressure. And depending on other factors, your diet, your genetics, the tissue will start to give way, and it literally starts to slowly avert. There's a degree of elasticity, so when you bear down, it'll obviously be at its worst, but then it'll relax back. The damage tends to be cumulative. That's why I say it's almost a slow-moving glacier. Over time, the more you increase your weight, the more you take groceries in, little things, it adds up and has a slow movement to it, and eventually it can result in the cervix actually coming outside of the vagina. Then proceeding further, the vagina will turn inside out, and the uterus will be inside the sock of the vagina.
I feel like this is a good point at which to interject that I feel like Dr. English just told me I don't need to do any more household chores for the safety of
that's
my...
That's exactly what I would say.
I'll write you a note if you come into my office.
I will be there bright and early tomorrow morning. Because I didn't even think about things like lifting groceries and things like that. There's repetitive things that you do that would impact this and in the long term.
Well, let's go to that. Actually, that's a great point. What are some of the risk factors of women who have this?
The more children you have tends to be a problem. The type of delivery you have, vaginal birth, forceps assisted births, or some of the operative techniques, they open a muscle hiatus called the levator hiatus. It's an opening in the basket of muscles that keep your organs on at the base. Damage to that separation or extension of that separation puts even more pressure on some of these support tissues. So being heavy, I had a woman who put on military tires on Oshkosh trucks when I worked in Wisconsin. Those 50 to 100-pound tires, they're huge. I can't believe the gal did it on her own. But doing all that serial lifting, I don't think she'd had kids, actually, but she developed prolapse.
Well,
wow.
It's interesting that you mentioned that, because I don't think we realize how much pressure gets exerted on our pelvis from different activities. And I'm just going to say that it is amazing if you just, like for example, in surgery, when you see somebody cough, and it's amazing what you can see just from the force of a normal cough or a sneeze in terms of what that can do to your pelvic organs. It's an incredible amount of pressure that we are asking our pelvic floors to support without due credit and appreciation oftentimes.
Even like, you mentioned the surgical examples, but after surgery, we say don't lift over 20 pounds for 6 weeks. Just bending over to tie your shoes is 70 pounds of intra-abdominal pressure.
70
What?
pounds?
70 pounds. It's a Harvard study from, 4 or 5 years ago. So people violate these rules constantly.
Wow.
Yeah, because when you think in terms of weight, you just think, don't pick up this object.
Right.
Don't, and like I said, I would have never thought, and mind you, our running gag is I've had 3 kids, so we always say the first one stretches you out, that second one really pulls on that third one and just breaks it. Yeah. And and that
Is that what they say?
Well, that's what we say. I mean, I tell my 8-year-old all the time, yeah, you're the one that broke me. I love you, but you broke me. But that, I mean, just the idea of that, and I've never even factored in that. I mean, I grew up being, I'm a pretty above average size. I'm not a very big woman, but I'm a pretty stocky woman. I was an athlete, and I've always had, a very sort of, I've always been sort of stronger than average. So, I mean, my husband and I never hired moving crews. I move furniture. I move heavy objects, like that's, right. I don't, my kid jokes about it in the house when he needs something. It's like, I get mom, she's strong like bull.
The lady we saw today has been moving, and it worsened her prolapse significantly to where the uterus and cervix were coming out into this skin sock, basically the vagina.
That's right.
Listen, I just feel like, and now I have witnesses, and the listeners will back me up on it.
She's 70 years old. What is she doing moving socks or boxes? Socks. She can move your socks.
But you know what though? But I get that because I know how I am at 43, and that I feel like I might have lost a step, but to me it's just a step. I would still probably continue to do all of these things. Hearing you talk just reinforces that I need to go home today, put my feet up, and no longer do anything.
That's right.
Except sip lemonade and point at people to go do things.
I would support that.
I would support it. I'd sign the forms.
So you were talking about just the very process of having a baby, especially what type of delivery, and what can you do about that? And you can't control so much about that. And there was somebody. I know that there's been some discussion about the idea of doing C-sections as a way of preventing prolapse. What are your thoughts about that?
The studies haven't exactly. It's just carrying the baby's a risk.
Yeah, just having that great big old fat baby sitting in your
and I mean it's added risk to come through a little bit, but. They don't, at least in the United States. Other countries might feel differently, like Brazil or Turkey, where the C-section rates are 80%. They have their own thought process on these things, but
their C-section rate is 70%.
80, I thought.
80. Wow.
Yeah, but no, here in the U.S., we've done a few studies, and I'm sure they'll keep studying as time goes on. But the costs of C-section are significant. No one wants to particularly go that route, but it has not.
Really been shown.
But yeah, it hasn't borne fruit. So,
is there any sort of connection to like people? I noticed in the last 10 years, 12 years, a lot of my friends that continue to have children were doing things like VBAC, like they had a cesarean and then they wanted to have a vaginal birth after that because they wanted the experience.
Yeah. I don't know if that might make it worse. One of the things, there's a great deal of distortion as the head comes down and out, and as the baby. The term we use is crowning. As it pulls that tissue, it actually crowns. It comes away from its normal position, 5, 6, 7 centimeters sometimes. Having the tissue pulled that way, the nerves are not elastic. They think it's causing nerve damage, actually, and it's contributing to... It makes sense that it would. You get a neuropathy for sure. Sometimes nerve-related impairment, so the muscles don't contract as well afterwards. And that's why some people have argued, well, we should cut more episiotomies. And Eric, Dr. Heegaard, and myself, we can tell anybody, they don't want us to cut episiotomies. They want natural births. So we'll see what happens to the rates of pelvic prolapse as time goes on. But when there's a certain amount of distortion, at least in my personal practice, I will cut an episiotomy. I have average episiotomy rates, but I don't let the pressure build up very long or to that extent because I'm afraid it's doing all sorts of other damage to subcutaneous tissues.
So method of birth, the very fact that they're giving birth at all, and then you talked about heavy lifting. You know, I know I've read about chronic constipation, chronic cough.
Right, anything that putting that degree of pressure on it. You don't have to have kids to have be applying great deals of pressure, and that'll do it. It's just like having a kid.
And also, you'd mentioned before genetics. I mean, some people's just the condition or their connective tissue that holds everything up is different.
Yeah, and they'll say, "Oh, Mom had this same problem." I had another lady in the afternoon here who said, "Mom, my mom had this problem. My grandma had this problem." So, and we know, for example, Caucasians seem to be a particularly high risk. it's true. They have different connective tissue types, and they're just not as strong in some tissue.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
Is there anything, we can't really do much. If people are going to get pregnant and have babies, we can't really prevent that, right? But is there anything that people can do for women who are listening to the show? Is there anything that they can do to try to make the risk of this happen, or pelvic floor prolapse, less?
Yeah, just stay healthy, eat right. Smoking's kind of going out in our society, but that was a major impairment.
Smoking has gone out in one facet of our culture, but we are now in the sort of vaping times, and we are rapidly hitting the marijuana as legal entity times. So that's going to be a whole other sort of set of,
I don't know if they've done a study on that, actually, but you're right. You're absolutely right.
But smoking...
That's a study idea, actually.
Your point is that smoking is bad for connective tissue. It's just bad.
It is. Yeah.
It's bad for everything, basically. But
right.
For our supportive tissue, it's not good.
No.
So don't smoke.
Don't smoke. Stay healthy. Like routine lifting of weights and things. These things remodel collagen and make your collagen as strong as possible. There's no perfect answer there for prevention.
So let's talk about treatment. What do you do for the, you can prolapse the bladder, you can prolapse the rectum and the uterus and cervix and all that. What are the options in terms of treatment of this?
Option one, I always tell people, because I start slow, is you can do nothing. You can watch and wait this thing. Wait till you find a deductible year that you want to do this kind of enter into a treatment cycle. But do nothing is the first option. Second option tends to be a pessary device. This is a latex implantable. You can think of like a mini Frisbee, an inflatable balloon, an umbrella, cubes, donuts. We've talked about that in one of the other podcasts we've done. But you can insert these devices to try to essentially plug up the hole. And like, for example, the cube pessary has little vacuum cups on the side. We fit them in, and it holds the position. It's like trying to plug the dam. And for some people, it's a great option for them because they're not surgical candidates for more advanced options. But for a lot of people, it would be pretty annoying, or they'd at least need a lot of help putting it in and out.
Well, and they need to be cleaned, and it can cause a discharge and an odor. So for many people,
the skin breaks down.
There's just, for many, at least my experience has been, for many active women, younger active women, they just don't want to tolerate that.
Yeah. I've had 2 people put something in and then just kind of forget about it, and they actually, their body healed around it.
Oh, heavens to Betsy.
It's terrible. So we saw it on CT scan, so I could see that it was clearly a pessary, and it creates a hell of an artifact on a CT scan.
Jeez.
Looks like a bunch of stars. Anyway, because there's metal on some of the ring components, but
I have never seen that. That's terrible.
Absolutely wild. And she did not want me to do anything about it, so we didn't. But it was a chronic problem for her. So
pessaries, as we were talking, and for those of you who may not, unfortunately, have listened to one of our other podcasts where we talked about incontinence, I'm just going to just throw this out, and I'm going to ask this, even though I'm going to ask Twila this, because I know English kind of pop my balloon.
Well, people should know, if you're listening to this podcast and you're curious about the other one, we'll link to it in the syllabus. You'll be able to reference that podcast too.
Okay, so what was the earliest documented reference to use of a pessary, Twila? Dang.
It was the Egyptians.
You are absolutely right.
I like sounding smart, not that I didn't hear that about 40 minutes ago.
And what did they use? Crocodile.
What?
Something. I don't know.
It was a pomegranate, wasn't it?
It was that was somebody. No, that was Hippocrates, I think, wasn't it?
Oh.
Used to have not a whole pomegranate.
Just a half. Waste not,
want not. What are you going to use on your avocado salad? Half for your vagina, half for your salad. But and so this has been going on for a long time.
Yeah, absolutely.
And in the old days when you didn't have fabulous treatment options, I think people probably just took whatever they had and they
plugged it up,
plugged the dam, like you said.
Well, it's just good to know that there are actual, like, safe, medically tested, I'm assuming surgical grade materials that you can use for this, because there's a lot of things that women just buy on the open market that aren't regulated by the FDA the way that we think they are, that we're using for these things, or things that we're, as women, jerry-rigging to work, in that way, and that's not what they're intended for. So it is good to know that if we're looking for an option, or we need an option, that we can go to a doctor and actually find a legitimate option.
That's right. So if either a woman doesn't want a pessaries, is not a good candidate for it, where do you go there?
Next, we would offer them 3 different classes of surgical repair. The first being natural fiber, natural tissue repairs. These don't have the best track record or the best longevity. It's
using their own tissue, or
basically,
tissue?
Our own tissue, and we sew it up. The people used to refer to it as they tied my bladder up. We put a number of stitches in, trying to create a large scar, and the scar would act as a new support structure. The second class would be donated tissue, either porcine, they'll use human tissue. That doesn't have a very good track record, however, and a lot of those tissue substances have actually left the market. I know they were using that a lot for posterior repair of a rectal bulge called a rectoceal. That's the medical term we use. And they were getting kind of the same rates as natural tissue fibers, and here these substances cost a ton of money to process and to make disease-free before we can implant them. The last class is implantable meshes, which have taken an absolute beating in terms of people's perception due to class action. But those are separated into 2 different groups: the vaginally applied meshes and then the abdominally applied meshes. The abdominally applied meshes, no problems. No erosion issues, no class action, no FDA actions. The vaginal implants I used to do, and you'd make an incision in the vagina, work in a new mesh wall, because your tissue wall is failing, and it would cause an erosion because the skin would not heal back over.
Well, it disrupts the blood supply.
It does.
To the vaginal wall.
You can't get it in the right space when you do it that way. It's just, as someone who did it and tried very hard, you're doing it somewhat blindly or by feel through the vagina, and a lot of gynecologic surgeons pride themselves, like, I do everything through this small opening, and it's not the right approach. It just isn't. So what I predominantly do is called sacral colpopexy, and we add incontinence slings in a certain percentage of people where we think the extra support of one of the walls is needed. And there's another subset of folks that have a rectal issue as well. We'll work with colorectal to work up that issue, and we'll combine it. So basically, we kind of create a brand new pelvic structure in total. A one-time surgery that has a 99% success rate.
It's really revolutionized this.
It really has.
The treatment of this condition.
Yeah. The sacral colpopexy as a procedure, as a thought process, has been the gold standard since like the late 80s.
Right.
But unfortunately, before, we had to make this huge midline abdominal incision.
Right.
It took people 6 days to heal from. Any open abdominal incision, high complication rates with infection, adhesions, bowel obstructions. With the new robotic laparoscopic equipment, we can do it all through usually three ports. And they're small, and it's an outpatient procedure. You spend 24 hours in the hospital and typically you're home the next day.
Yeah, it's really, and the post-operative results of these are just fantastic.
Tell. Yeah, you literally can't tell if there's anything in there.
Yeah.
Because it has a single strap pivot point. Anyway, it's all attached to one spot. It's like it's on a trapeze. There's motion to it, elasticity. It really feels like a normal pelvis again.
And
wow.
And it draws the top of the vagina up to its normal kind of anatomic position.
Right.
So it restores the normal length of the vagina, allowing them to have intercourse.
Right. We call it stage 0 in the business.
Is that what they call in the business?
It goes
Stage
right
0.
back to square one.
Yeah.
So pre-kids.
And it's just,
see, now I'm worried that people are going to start trying to seek that. They're going to listen to the podcast and come talk to you when they get vaginal rejuvenation. I would like a 20-year-old vagina again. Let's see what we can do about that.
You got it.
That's another podcast. But it's, having seen you do many of these, it is really, and also having done this not long enough myself, where we've gone from kind of trying to do these vaginally, to trying the vaginal meshes, to, I think we're all people who are interested in this issue and gynecology. We're scratching their heads trying to figure out what is the best and most effective way to manage this, and it really has gotten. I think pretty much everybody agree that this is probably the best procedure for most women, the sacral colpopexy.
A lot of people do. There's some dissent in the field. There are a lot of transvaginal devotees within my subspecialty, but I can't argue with my own results. There's a lot of national studies that show outcomes are fantastic, complications are low, reoperation is almost zero, and it's successful. In fact, I have this subspecialty of female pelvic medicine, reconstructive surgeon, what we're now used to call a urogynecologist. There's a number of jokes we can tell about that, but someone that knows colorectal, bladder, and gynecological principles, they came up with this whole field in response to the mesh issue, because people that were barely trained were trying to go in there and fix these things, and the catastrophe that some people can make out of a pelvis would surprise you. And I know it doesn't surprise Dr. Heegaard, because he deals with endometriosis-related catastrophes and other things. If the wrong person is doing your case, it's not good. So they did. They created a board certification, and they should probably do it for pain and endo and a number of other things. But
well, so so people kind of understand, I'm trying to visualize this. The thing about this sacral colpopexy is that you're laying. I'm just trying to describe this so people can see it. You got the tube of the vagina.
Yeah, I like to refer to it as a sock. It helps people visualize it, but it's a Y-shaped mesh. It's got two arms and then an attachment arm. So you can think of three different little arms. One goes over the top of the vagina, one goes over the back side of the vagina, and then one we attach to connective tissue fibers that cover basically the sacrum and the lumbar vertebrae. There's no pain neurons there, and that's tough stuff. So we use permanent stitches. Yeah. The mesh we use is permanent and has a little bit of an elastic component. None of it breaks down. You can't break it after it's in.
So basically one goes over the top, one attached to the back, and then the other part anchors.
Correct.
Yeah. And so it's sandwiching the vagina. And I think the thing that Dr. English was describing before is that you're not disrupting the blood supply to the vagina. You're not opening up the vaginal wall at all. You're just laying it on top.
Yeah, full thickness application. So you're right, you're not separating it into multiple little sublayers. And some people say, well, I don't have a problem with my rectum. Why are you putting mesh down the back on the rectal side of the vaginal wall? If you have a connective tissue problem and we fix your bladder only, I bet you 15% of people, your body, the more you lift, cough, all the things we've talked about, it'll find the next weakest spot.
That's right.
Oh.
And it'll start blowing out the rectum. Now you got to go do the rectum. You chase your tail. And that's why the sacral colpopexy, it covers all three of the prolapsal compartments in one surgery.
Okay.
That's right. And like Dr. English said, this is done. People go home the next day. And I've always been sort of surprised about, for many people, how little pain they have. It's sort of surprising.
It is surprising.
For the amount of for the size surgery it is and what you're doing, it's people really tolerate it very well.
It qualifies as a major surgery, but almost as you said earlier with the sandwich thing, the body has natural tissue planes. We're really working within those natural tissue planes. We do very little cutting per se. It's all just blunt separation. We lay this thing in and put in a few stitches, and we're done.
So how long? So sort of walk me through the landscape of this surgery. If you had this procedure done, how long would it take? What would your recovery look like?
Yeah. Usually takes us an hour and a half from start to finish to do it, depending on how many added components there are. A certain number of people, when they've had prolapse for a long time, for example, the vagina will gape at the opening. We will repair the gape and tighten the opening. That's a form of vaginal rejuvenation, I guess. But that'll take another 15 minutes, for example. Okay. But it's not a long procedure. That's not an 8-hour slog fest. The blood loss is minimal, a test tube or so. People spend the night, overnight. They generally rate their pain 2 out of 10 the next day. We'll do bladder trials to make sure they can pee, and by about lunchtime they go home.
Okay. And then what kind of recovery are they looking at once they're home?
For 2 weeks, I tell them to sit still. For 3 to 4 days, they're using narcotic pain medicines, and then they usually feel pretty good. Then they want to cheat and they want to go walk the dog
We're
because they feel
girls.
pretty good.
We're women.
It's like,
we're
don't do
stubborn.
it. Don't. I know.
Yeah.
But I know. So if I tell people, really treat it with respect, even if you feel great for 2 weeks, because after that point, I'll let them trial doing more of their normal activities. And usually by 3-4 weeks, people are doing all their normal activities.
Oh,
But
okay.
and how long do you want, before they do any significant lifting, how long do you tell them to wait?
I tell them, listen, between the permanent stitch and the mesh, they cannot break what I've done. The heavy lifting is a form of vigorous activity that's going to aggravate the surgical margins. So I'd prefer them wait like 3-4 weeks.
Yeah.
I just saw a woman who had a pretty vigorous job. I think she was a nurse of some sort. I told her wait 4 weeks. She's moving patients. It's not light stuff.
Mm-hmm.
Yeah.
In fact, maybe it contributed to her prolapse.
Oh.
Here we go. I know it's hard. You got to stay functional. And listen, that's just what life is: groceries and vacuuming and all these things for all of us. So, if you're having the trouble, you can't.
Not anymore. I'm starting a
Can't be a
revolution
shrink.
around here.
You're not going to go.
I'm
you're never gonna lift again.
I want to institute a retirement age for my health.
Just put it on my forklift. Just drive around.
Personal forklift. So I want to just go back to this and just to say that this is a problem again. Pelvic organ prolapse is actually surprisingly common. It's not something that many people talk about. And again, I want to just say that we as gynecologists are used to talking about these very intimate details. And so if you are having incontinence of your bladder or problems with incontinence of your stool or gas, if your uterus is falling out, you got to please come in and see somebody like Dr. English. He has heard it all. It's not embarrassing to him, and we will make it. I promise you, we will make it comfortable as possible to talk about these important things. And beyond that, as Dr. English has said, there are fantastic treatments for prolapse. You do not have to live like this.
No.
And so, please get in and get it evaluated and treated, and so you can live a long and healthy life and do what you want to do.
A lot of times, the sooner the better, too. As people get at advanced age, atrial fibrillation, some of their medical conditions catch up to you, and now you're no longer a candidate.
Yep.
So
you don't want to. So if I'm understanding what you're saying, you don't want to wait. You don't want to jump the gun too early, but you don't want to wait too long either.
No.
All
So
right.
are these sort of regular conversations you should be having, say, with you, Dr. Heegaard, as the gynecologist when we're coming in, sort of as a tracking mechanism, like I'm having this little bit of issue, I'm having this little bit of issue, or what have you. So then, if you kind of keep at your regular appointments, if you're keeping a record of it, then you kind of know when you're at the point where it's time to shift over to Dr.
Exactly.
English.
So as a gynecologist, whatever you kind of focus on, we should be, ideally asking these questions, and you want to feel comfortable mentioning it to your doctor, whether it be, issues with sexuality, issues with your bladder and your rectum, and that sort of thing. And if you don't tell us, sometimes we're just going to assume everything is fine. But, so what we would do, and I have a number of patients like this who have some prolapse, and I talk to them about the options, and they're not ready for surgery yet. They're not at that point, but we can monitor it over the time, and then when it gets to the point where I think that they need surgical evaluation, I'm going to send them to Dr. English.
Okay.
And so, but if you don't, we need to have a conversation.
Yeah, but we say this all the time here about being an advocate for your
right.
health. So your doctor can't really help you if you're not being open with them, if you're not being honest with them.
That's right.
And there's no such thing as a dumb question or a dumb thing. Ask, and then you can find out if that's something that needs to be prioritized, if it's something not to worry about. I mean, sometimes putting that information out there can get you information in return that can put you at ease.
That's right.
Yeah.
So
That's right.
I agree.
So, Dr. English, thank you for joining us again. To talk
Thank
about
you.
This important
Yeah.
subject. And thank you for listening. And please look at our other podcasts because we have many fabulous podcasts.
yes, we do. Don't forget, if you haven't already done so, go to Facebook. Keep the conversation going. Go to the GynoCast on Facebook. You should already be a member, but if you're not, just click on the little button that says, I would like to join, and we'll let you in. We vet everybody just slightly to make sure that the group itself and the integrity of the group is maintained.
That's
we
right.
have mature conversations. We have difficult conversations. We have fun conversations. But all of them are with an atmosphere of respect and support, and we want to make sure that we continue to have that occur the same way.
That's right.
If you have questions for us or comments about the episodes you're listening to, there's a send message option on that page. Click on that. You can actually get in touch with us. You can give us information. You can ask us questions. You can even be anonymous there if you need to be or if you'd like to be as well. And Dr. E's right. As always, this is one of many podcasts. If you go to the GynoCast Facebook page, we have links directly to the Matriarch Digital Media website, and you're able to find out more about us, about our shows. You can get the syllabus from our episodes that gives you more information about the topics at hand and many other fun things. So,
Yes.
indeed.
All right. See you soon.